Okay, we will begin. Again, greetings from Kehpca and from myself. My name is David Musyoki, and I serve at Kehpca as the Executive Director. And it's really great to have this session, uh, about an hour, discussing and having some thoughts around transformational leadership, governance, and aligned to palliative care, which is the main cause for the National Association, the Kenya Hospices and Palliative Care Association, who are the hosts for this webinar. We run webinars at least once every month, on different matters that are linked to palliative care. And this topic today is one of the aspects that is key to us as a national association, because without really proper leadership and governance, it will be very difficult to have good palliative care services and good palliative care initiatives in the country and in many other places. So based on our assessment and the feedback that we receive based on our work and continued shaping of palliative care in the country, we felt, and it was deemed necessary, that we have this conversation. And being an umbrella body for palliative care providers and for hospices, we realized that there are certain needs and unique needs for the palliative care providers, and leadership and proper leadership becomes part and parcel of what we advocate for sustained palliative care initiatives and for good services to patients with life-threatening illnesses. So based on that preamble, we are glad that we reached out to Dr. Timothy Olweni, who gladly accepted our invitation to be our speaker today. And Dr. Olweni is this great gentleman. I met him first when he was the chair at the Nakuru Hospice, and he served in different capacities. I may not be able to outline the entire profile of his, but certain things stand out. That he studied as a doctor, then studied in leadership and management from a serious university in the world, the University of Washington, which is quite something. And he's led different institutions and at different levels. The recent leadership appointment that he's had include being the chair of the board of SHA, which is the talk of town. And currently is the chairperson at the NCI, the National Cancer Institute of Kenya. And we work with these bodies in different levels, and through his leadership, we can attribute many aspects of transformation. He is a palliative care champion. And so, Doctor, I don't want to take so much of time, but we acknowledge your knowledge, and we are happy that you've decided and agreed to share some of that knowledge with us tonight. Thank you for being here, and I'll request our audience to keep your questions. You could write them on the chat or on the Q&A, and make your notes. We're recording this, and what we usually do, we also upload the recording after the session on our Kehpca YouTube page. So if you have any questions, we'll have a great interaction after his talk towards the end, and we'll be happy to pick your questions or comments. Dr. Olweni, welcome to give us insights and to present on this important topic on transformational leadership, and again sharing your experiences to help us reflect on how to get better our centers and our institutions, matters palliative care and other fields. Makofi kwake as he comes.
Thank you very much, David, for those kind words in terms of introduction. I hope everyone can hear me clearly.
Yes, you're very audible
Okay.
and with fine English.
Yes. So I'd like to give you a little background. You know, my interest in palliative care actually started many years ago when I graduated from the University of Nairobi in the early 90s. That's the time that I realized that I didn't have too much knowledge in terms of palliative care. There was a lot of focus that time in terms of training people when it comes to what we call therapeutic, what they was referred to as therapeutic or active cancer care for cancer patients. But especially for those for whom cure was no longer possible. It was not easy. In that time, that's the time I enrolled at the Nairobi Hospice in 1999. They had a doctor on rotation program. And that's the first time I tried palliative care because where I was in Nakuru, I realized there was not much knowledge in terms of palliative care. So it goes back that far. Of course, over the years, like David has mentioned, we set up a hospice in Nakuru. I've been in touch with the Nairobi Hospice. I've been in the palliative care space, but of course, as an active clinician, I also studied business because I run a hospital. And then after that, I've also had this leadership position. So more recently, I was the chairperson of the Social Health Authority, and now I'm at the National Cancer Institute. So that in general is my background. Now, the reason why I even accepted to give this talk is because one of the things, and you know, one of the WHO building blocks for for strengthening healthcare systems is leadership and governance. And that's one of the things that people ignore. And at the end of the day, you cannot be able to transform a healthcare system, at least have positive impact if you do not, in tandem, strengthen all those different building. So leadership and governance is important, and even for us in palliative care space and those who run organizations and hospices, I hope what I say today is going to resonate with what you need to do because in the absence of having the proper leadership and governance structures that are sound, you will be able to deliver care possibly if you're lucky, but it will not be in a sustainable manner. And that's one of the things that I hope we'll be able to pick up from this talk. So I've titled it Shaping Compassionate, Sustainable, and Patient-Centered Care. And of course, especially in palliative care, those words should resonate with you, the aspect of compassionate, sustainability, and patient-centeredness. Now, one of the things that I'd like to do here is to define what transformational leadership is in the context of palliative care, healthcare and palliative care, and then the governance frameworks that are relevant to palliative care, and also the impact of leadership on quality of life, staff engagement, and ethics. And then after that, of course, if we've got a few case examples and offer recommendations for implementation, because at the end of the day, we want people to be able to change their organizations in a manner that has got sustainable impact. I will not dwell too much on the aspect of palliative care because I want to assume that most people in this talk at this point in time are palliative care practitioners. Now, why does leadership matter? Especially in palliative care, you need multidisciplinary coordination of a lot of our activities. And then there are also a lot of emotional and ethical complexities. You know, I keep giving the example. If you've got an illness like malaria, which is something that is curable, and in essence, it is not something that is life-threatening, there are not too many emotional and ethical complexities when it comes to such treatment. When it comes to a time when treatment is long-term, it is life-threatening, it's got a serious emotional impact, economic impact, and a lot of other things because it changes people's lives. Then now the emotional and ethical complexities demand a greater level of leadership than you would in ordinary clinical care. And we also have systemic challenges because we have got resources that are constrained. They are always limited. It doesn't matter which environment you're in, everybody has got limited resources. And then there's the aspect about to do with stigma when it comes to cancer and palliative care, and then aspects to do with access, whether it's geographic access to care or whether it's financial access. So all those barriers need to be dealt with. And then the quality of care is also tied to the organization. So if you're a palliative care organization, for example, like a hospice, then the quality of care is closely linked to the culture which you have within your organization and the kind of leadership you have. And we'll see how those are interlinked. So transformational leadership is a leadership style that inspires and motivates employees to exceed their expectations and facilitate change. That's one definition. But if we were to break it down further, We talk about idealized influence. I keep saying that there are times when you've got a lot of, and I'll give a humorous example in Kenya. There are a lot of people who, when they're caught in some wrongdoing, the first response is, but I'm a Christian, I can't do this, right? And I keep saying that values are not spoken, they are not pronounced. Values, you live by those values. So if somebody is a Christian, you're going to see that based on their actions, not what they pronounce. In fact, most of the time, the people who keep pronouncing and saying, I can't do this because I'm a Christian, are the ones who are giving Christians a bad name. So when you talk about idealized influence, the same is true of leaders. You have got to walk the talk. It cannot be that on one end, you tell people that this is the values that we should live by, and then you do the opposite. In fact, that has got a negative impact on people because now you come across as somebody who's two-faced and not genuine interactions with them. Then there's the issue of inspirational motivation. You always have to be able to go through. In fact, I'll go through the strategy statements later, but people have to be clear as to why they're there, and you have to inspire them into action. That is what inspirational motivation refers to. Intellectual stimulation, it means you allow people to question. It allows innovation because there are always different ways of doing things. And in fact, that's one of the things I love about traveling and visiting different jurisdictions and different institutions, because you always come across and realize that there's somebody who's doing something in a manner that is slightly different from yours, and you always get to learn something. Either it reinforces what you are doing, or it makes you change what you're doing because you realize there's a different way of doing things that also works. Then individualized consideration refers to empathy. And in terms of as a leader, you must also be seen to walk in the shoes of those whom you lead. And therefore, it requires some emotional intelligence so that you can be able to interact with people and with society. So it requires a lot of social skills, people skills, and those are the kind of things that transformational leaders do. So transformational leadership in palliative care, we have said earlier, empathy-driven decision-making. So it has to be empathetic because, again, you must realize that you have to be empathetic to not only internal customers, so to speak, as in your staff, but also, again, to the patients that you take care of and their families. We have to foster innovation, and then again, shared values and goals. And again, I'll emphasize that when we go to strategy statements. But you realize that, again, the emotional toll on staff involved in palliative care is something that you cannot wish away, and it's something that needs to be handled and dealt with. So it has to be that you improve the morale amongst those staff. Governance. Governance in palliative care is important because these are the structures that, first of all, put processes in place. It allows you to make decisions based on sound judgment. It ensures that there's accountability, and also it acts as a measure of the performance. So you have to have some metrics by which you assess your performance. So governance can be clinical in terms of clinical outcomes, for example. There's ethical oversight, and the basic principles of ethics, of medical ethics still apply. Beneficence, non-maleficence, autonomy, and fairness with justice. And they are even more important, like I said, when you talk about chronic illness or life-threatening illness. And then there's also stakeholder engagement. There are so many stakeholders involved in palliative care. And the stakeholder engagement, I was always taught when I was in business school, that the stakeholders, you might not be able to maximize their well-being because sometimes their interests actually are at cross purposes. But at the very least, you have got to sustain their well-being. And therefore, all stakeholders must be able to have their well-being sustained. That's the only way that we can be able to engage them and be successful in whatever we intend to achieve. Now, when it comes to the composition of boards, and this is one of the things that I learned, and it's something I wish I learned earlier in my career, but it's never too late. And for some of you, I'm sure you're much younger than I am. So this is a good opportunity. First of all, you must have an effective board, because the board is the one that provides governance and oversight, and it's ultimately the policy-making organ for your organization. So in terms of board composition, first of all, the board composition must have people who are competent to perform the roles that they are required to do. Very often in our country, we have got people who are, for lack of a better word, are incompetent. And then we appoint them to positions and then get surprised that things are not working. So at the end of the day, the board composition is extremely important in terms of the level of competence, and then also the aspect of diversity. You have got very often, especially in the medical field, you can have boards that are so homogeneous that the thinking is the same. it is very important for you to have a board that is diverse in terms of composition, because they always bring different perspectives and different levels of expertise. So, for example, people in the medical profession like ourselves might not be very good in areas to do with finance and accounting, for example. So there has to be somebody who is proficient in that. There might be the legal dimensions and so on and so forth. So you'll find, for example, in statutory bodies like in government and so on, the board composition is defined by whatever legislative or legal instrument brings the board into being. However, you might find that for other organizations, for example, even like with our hospices, it might be discretionary, and that's why it is important that we emphasize that aspect about diversity. So the board composition and structure is important. It cannot be too big, it can't be too small, and the usually recommendations, most of the time they talk about 9 to 11, and the reasons usually needs to be an odd number, but those are details that I'm sure you'll be able to read around and find, but the board composition and structure is extremely important. Then there's an aspect about the roles and functions. Those have to be delineated and have to be clear. In fact, very often in our country, we find that people are not very clear about the difference of the roles between the board and management. And you have got overreach both ways. So sometimes you've got management trying to send things to the board, which should not get there. And at the same time, you've got board also overreaching, and instead of keeping their eyes on and hands off, they want to start performing management roles. So the roles and functions need to be explicit and they need to be written down. Then there's the aspect about strategy statements. And I talk about strategy statements because, first of all, it is important for people to know what their purpose is. An organization has to know the reason why it exists. So the business purpose is the reason why you exist. So for example, in palliative care, you might find this defined as the reason you exist is to be able to improve the lives of your patient. It might be something that general, but in essence, it has to be, you have to know why you exist. Then there's the mission. That is what you do and who you do it for. Those two are different, because what you do and you do it for, who you do it for defines who your constituency is and what you do. So we have said the purpose is why you exist, mission is what you do and who you do it for. After that, there's the vision. Where would you like us to, where would we like to be? Then there's goals and objectives. Now that goal breaks down into the nitty-gritty of what you want to specifically achieve. And those goals and objectives, I'm sure everybody knows about how they need to be smart, they need to be specific, measurable, and so on. Now, when it comes to values, and this is another extremely important aspect when it comes to the aspect of strategy statements, it goes down all the way to governance and so on, is that the values, it defines actually who you are. I always have a problem when you have people who are not clear of what the values in the organization are, because that's a serious failure, because values act as a moral compass, help you in every single day decision making. So if it is not aligned with your values, you don't tread there. And if it's something that's aligned with your values, then you champion it and you make sure that it gets done. So that's in terms of governance and oversight. That's just a brief overview, and I think most of the other aspects we will cover when it comes to the question and answer session. So in palliative care, we've got integrated care models. I've talked about the WHO's building blocks. Then we also have our care policies and standards, even within our own country. And then you also have a framework through which we ensure that we not only maintain, but also improve quality of care to our patients. Now, where do leadership and governance intersect? Leadership ensures that governance is values-based and patient-centered. So values, I said, is the moral compass, and patient-centered because we are going to be focusing on the patient and their families. So it cannot be that it is driven by the agenda of the organization. It has to be based on what the patient's needs are. So the governance supports leaders through clear structures, policy, and accountability, because even leaders need to be held accountable. They need to be clear what their roles are, and they need to be held accountable in terms of their performance. Now, you find when it comes to end-of-life decisions, dilemmas that we always have about resource allocation. How do you allocate the limited resources that you have within your organization, and also within for each and every patient you take care of? There's always going to be the question of how we allocate those limited resources, and then also again the issues of staff, their training, and their well-being. Those are the things where we got the intersection between leadership and governance, and those are important considerations. I've mentioned the aspect about the ethical dimensions. The respect for autonomy is extremely important because a lot of the time we tend to project what our own values are and what our own intentions as healthcare professionals. But at the end of the day, we have to be very clear that we listen to each individual patient and family and respect their autonomy, even if it gets to a point where, for example, they disregard our advice. It becomes one of the best things to do is to be able to respect your patients' views. Now, there's always different ways to do things, and especially in the cancer care space or in palliative care, for that matter, there's always different decisions and different ways that decisions can go. And conflicts are going to arise. Conflicts between even individual healthcare providers, conflicts between patients and their families. Sometimes you want to go on different routes, and we have to be clear that as we navigate that, we always remember it has to be patient-centered, and therefore the patient's views and their opinions and their autonomy must always be respected. And there's the aspect about dignity and human rights. And one of the things I remember, I know as the National Cancer Institute, one of the things that we is part of our mandate and we have to make sure that we always deliver on is that the civil liberties and rights of patients with cancer are always protected. And that includes their dignity. Because, for example, you get situations where people are denied opportunities on the basis of cancer diagnosis. And that in itself is discrimination which should not be allowed. So there are various times when people are denied opportunities or when the people are stigmatized, and those become one of the main considerations when we're talking about patients with cancer. In fact, their effects sometimes are even more debilitating than the disease itself. And then leadership must promote an ethical climate. And I've said it's not just an issue of ethical climate, but it has to be ethics, it has to be integrity, and it has to be, I've said we've got to walk the talk. So those values must come through the leadership so that everybody sees that there are things that you intend and are meant to be. How do we measure success? Patient-reported outcomes. So you get feedback from your constituency, the people you're taking care of. You have to get patient-reported outcomes. Then the other thing is another metric for success is how do you retain staff? But one thing talent acquisition is one thing, but how you would retain them and what level of morale do they have? Then there's the clinical outcomes. So patient-reported outcomes are very different from clinical outcomes because patient-reported is from the patient's perspective. Clinical outcomes are based on what your peers judge. And then there's also compliance with ethical standards and guidelines. So those are the things that we're going to use as metrics for success. So what we recommend, first of all, is we have to invest in leadership development. Very often what happens is, and I know from the palliative care movement in this country, especially for hospices, it started off as something that was donor-driven. So all the time you see when you got what I call aid with strings attached, they give you assistance, but the assistance is earmarked for specific things, which according to them is what is important. That might not be necessarily be what your immediate needs are as an organization. But leadership development is extremely important because in the absence of you investing in the right leaders, and that's why it becomes extremely important that, for example, you've got people who are level 5 leaders. There's something called level 5 leadership. You invest first in who? You have to have the right people. And sometimes what happens is we compromise because of lack of resources. We don't get in the right people because we say we can't afford the right people at this time. That costs you a lot later because it jeopardizes, it negatively impacts on the potential growth of the organization. And then in addition to that, once it has stifled your growth, you can't be able to realize your objectives. So first you have to have the right people. And then after that, you've got to have the right thinking process. So it's about discipline. Discipline in disciplined people, you have got to have disciplined thought, which is strategy, and disciplined execution. So it is all those three things that have to come in place. Then government structures, they must empower, not just control. So what it is you've got to strike a balance between setting governance structures that constrain people not to be able to do the wrong things, but also give them the freedom to innovate and be able to do the right things that can be able to take your organization to the next level. And then there's an aspect of ethical audits and debriefing of teams, and then engaging communities. Because at the end of the day, we talk about being patient-centric. We must make sure that we're listening to the community and addressing their needs. That's the only way that this model can be sustainable. Otherwise, if you're providing care that is not aligned with people's cultural values or their spiritual values or whatever it is, then at the end of the day, they're going to come and access your care. So the model is dependent on engaging the communities, getting feedback from them continuously to be able to realize whether or not you're meeting the expectations. So in conclusion, I'll say these are the cornerstones of high quality palliative care: transformation leadership and robust governance structures. That is important. And also when it comes to the culture aspect, you have to have compassion, accountability, and excellence, where we're delivering on what the people expect and meeting what their needs are. And then we need adaptive, visionary leaders and systems that hold people accountable. That is the future of palliative care. Thank you.
Wow, great insights, great sharing. I picked quite some stuff, especially around idealized influence. What transformational leadership is all about, the aspects around inspirational motivation, and then individualized consideration. Things and very emphatic, especially around governance, the importance of having structures and processes that assist in decision making, making our institutions and ourselves accountable and able to perform, or else to be able to say we are performing, these things needs to be in place. And so I'm just making a reflection more specifically and skewed to what we do, the palliative care space and the landscape that we operate under. And again, it's a reflection to all of us, and more specifically the providers of palliative care. Probably, how are we? Where are we? What are our needs? How do we improve what we have? And I think this is a great reflection, and I'm happy to also make a reflection for Kehpca that at least we have a great board of governance which governs what we do as a national association, and the roles of the governors and the roles of the management should be very distinct, even based on what Dr. Olweni is saying, which is very key. Otherwise, conflicts become order of the day. I am sure in our different other capacities and in different other spheres of our work, this kind of talk is a great reflection to what we do. And so I will open it up for interactions. If you have any questions or any comments, we'll be happy to take them. And feel free to ask any question. Dr. Olweni will be happy to take any questions or comments. If you need to speak, you can lift your hand. We'll be able to unmute you. And then you'll be able to say what you need to say. I am going through the chat box, and what I see are introductions. I don't think there is any question so far. I saw several appreciation hands which acknowledge at least a good talk. Thank you so much, Dr. Olweni. Is there any question or comment? And the IT team could assist me in the event. I can't see anyone. Thank you for the hands. I think it's Rick Warren, if I'm not wrong, the great leader, the great scholar who says everything falls or succeeds depending on leadership. And so if we have successful palliative care programs, it's because of good leadership. And not only palliative care, but in any other sphere. So yes, being at the national level, we really are looking forward and continue to support palliative care initiatives. And definitely part of our support is to advocate for good leadership so that any patient and any family faced by life-threatening illness would receive that kind of care, quality care that they so need and so require. So again, this is to implore on all the palliative care providers that we make a reflection and see in which areas are we doing well, then we strengthen such. And are there areas that probably might need some kind of review and revisit? Then the National Association is here to provide that technical support with our key stakeholders, including Dr. Olweni and other team members. I'm sure he wouldn't mind giving more specific inputs where necessary. Part of our work includes doing or developing sort of like templates for governance structures, like policy documents that guide leadership. So if your institution so needs such, let us know. We'll be able to facilitate where we can. I see the comment from Dr. Esther Mwinga. She asks, are there tips on how one navigates high staff turnover in an organization? Doc, you can take that.
Well, yeah, thank you for the question. Of course, our organizations are usually different in terms of the staff composition, in terms of also the demographic, and all these things play when it comes to high staff turnover. And I'll give an example. You've got different, for example, different age groups within our country, and you will find that there are a lot of assumptions that you say what would define a good work environment for an employee. Sometimes it has got something to do with the pay, but it's not always about pay. A lot of the time they say that people leave their supervisors or their leaders and not even necessarily the organization. Again, there are times when the organization itself is not meeting their needs in terms of, for example, work-life balance, just feeling appreciated. So one of the things is to be able to be, and that's why we talked about paying individualized attention to employees. It is very important to understand the people you work with and understand what their needs are, and always have a feedback mechanism via which you can be able to figure out the reasons why there's dissatisfaction. Because what usually happens is by the time somebody is leaving, people don't just wake up and leave. A lot of the time, there are certain conversations they've had which have been listened to or that have been disregarded. Another good practice, again, is even when people leave, it's good to have an exit interview to be able to find out what those reasons were, because chances are any of those reasons why they left are not unique to them. There are going to be other people who are affected by the same thing. But the key thing is to be able to have a work environment where people feel valued, where people get job satisfaction and get some degree of work-life balance. So sometimes about giving people flexibility. For example, a lot of organizations that say, oh, you have to come here 8 to 5, right? Someone might be telling you, oh, I need to be able to take care of this. I'd rather come in at 7 to 4, for example. You find some organizations will tell you no. And if you think about the real reasoning why somebody's saying, no, that can't work, if they're still putting in the kind of work that is required. Post-COVID, for example, there are a lot of jobs, again, that people got where it gives people flexibility about which location they work for. So there are a lot of things. So I know I'm not giving you a straight answer, but in general, it has to be that you listen to your employees and always get active feedback and act upon it. That's the only time people will feel that their value in the organization and their input is taken into consideration. Thank you.
Thank you. Hashtag being able to receive active feedback, and then you work on it. Then other question is around mentorship and continuity from Emily. Mentorship and continuity has been a great challenge. What should we do?
For most people, I think, even as professionals, by the way, it is one of the things that we are actually almost commanded to do. Because for you to be able to have continuity in an organization, it doesn't matter what kind of healthcare professional you are, for example, or any other professional. The truth of the matter is everybody's got a finite period during which they will be able to act. And it becomes important that we're able to hand over those skills. And skills is not just purely professional skills. Mentorship involves more than that. It's about being able to handle themselves in their work situations, in terms of social skills, in terms of their lives, And that becomes important for continuity. So it's a challenge, yes, but it's something that we have to encourage a lot of people to be able to do, and so that we can have continuity in our organizations. So that is something that's extremely important, and it's something that is learned. In fact, there are a lot of organizations that we have where mentorship is not a component. And sometimes what happens is people say that, oh, what's the point of training or mentoring other people, and the turnover is too high, for example. They're going to leave the next day. But that doesn't mean, you see, at the end of the day, you will mentor someone. Even if they go to another organization, you'll also receive somebody who hopefully has been mentored by somebody else. So this is something that we need to put into our work culture and make sure that we mentor people. But again, you can only mentor someone if they see you as a role model. And that's the important thing. Because other than that, then it becomes that you're just talking or giving them a lecture. It has to be that, first of all, they see you as a role model and want to emulate what you do. So it puts a certain, so when you say it's a challenge, sometimes you have to have some introspection and figure out, is it a challenge because people don't really aspire to be who I am? Or is it that it's a challenge for other reasons? So a lot of the time, and it's like a child, you can see, for example, even in households, when people are at a certain age and they look at their father and they look at him as somebody whom they aspire to be, children even walk and imitate their fathers when they're walking or how they sit and so on, because they aspire to be there. It's the same thing in organizations. People must first of all look up to you for you to be able to mentor them and them to be able to learn from.
Great. And probably tied to that, someone, I think 2 days ago, mentioned something while just in a conversation and talked about founder syndrome. Probably you could tell us something around that. And then Sophia asks, in what way does leadership influence cultural norms on death versus palliative care?
I think leadership influencing cultural norms on death and palliative care. In fact, I think sometimes, all the time, it might be the other way around. It is the cultural norms that influence leadership. And you know, all of us come from a background where we have got a culture. And I'll give an example. You know, in African culture, for example, if you look historically, we were fairly open to discussing things to do with death and surrounding death. Now, I don't know whether it comes with modernization or whether it comes with religion and Christianity, for example, being the predominant religion in our country. All of a sudden now we have got circumstances where people don't want people who are facing imminent death, I'll say imminent death, or for whom death is going, looks like it's going to come sooner rather than later. That's how we operate in the palliative care space. We've got people, even within families, when you've got the person who is facing, who is staring at death for whatever reason because the illness is not curable. If somebody, for example, says, "Oh, I think I'm dying soon. I need to talk to my family," the family's knee-jerk reaction is to say, "Don't talk about it." Right? And what that does is, first of all, it doesn't allow the person to be able to express themselves and give what their last will and testament or would be, all right, and tell people what their desires and their wishes are, especially even around what they would prefer around death and dying. And that's how it impacts on palliative care. A lot of the time, you've got a lot of people who end up, for example, being taken to ICU and put on life support when they've got terminal illness, where it is not necessary. It is purely because we didn't give the opportunity for them to be able to express what their wishes are. And that's why I'm saying, even in terms of leadership, it means that, first of all, you must have, I keep saying, you need to be strong enough to be gentle. You have to be able to listen to people, even when it's distasteful. Because even as a family member, sometimes you've got somebody who is expressing a wish, which for you find distasteful or difficult, but you have to allow them to express it, because at the end of the day, ethics dictates that, again, it is their wishes that have to override ours. So cultural norms, for example, around death and dying, and in our country, we have a lot of work to do. Because, for example, when you talk about even just things about do not resuscitate orders, it's a challenge in terms of implementing that, because I remember a specific case when you have a wife who the husband says do not resuscitate, and that was his wish. But she was not able to put it in writing, because she said the brothers of the husband, the family members of the husband, will view it as, you said, even if anything happens to him, let him just go. As in, basically, it comes across as somebody who doesn't care. So a lot of these cultural norms, we have to navigate through them. But through leadership, we can be able to, first of all, have these difficult conversations, bring them to the fore, and you realize a lot of these conversations can only be had before you're in that situation. Because if it gets to the point where the person already cannot make decisions on their own, it's too late. So you have to make those decisions and do have those discussions prior to that event. And that's where leadership also comes in terms of bringing those discussions to the fore in a sensitive manner, sensitive to the patient's circumstance, to their cultural norms, to their cultural values, to what their financial situation is, and so on and so forth.
Thank you. Great insight there. Edgar seems to ask a specific question for the Cancer Institute. What is the Institute doing to minimize negative political influence in both palliative care service and management in devolved units? And I'm not so sure what the political influence would be in this case. Yeah.
I'm also not very sure what the negative political influence refers to, but at National Cancer Institute, our mandate is to be able to basically manage everything to do with the prevention, treatment, and control of cancer in Kenya. Now, this does not necessarily mean that we do it ourselves. It is going to be in terms of leadership, it's going to be in terms of oversight, and it's going to be in terms of coordination, collaboration, and various other things. So in terms of the political components, the political aspect, I'm not too sure they're talking about politics influencing particular organizations. However, you do know that health is a devolved function in this country. And that created a bit of a complication in terms of managing healthcare services in the country in general, and even in palliative care or in the care of cancer patients, because technically we have 48 governments to deal with. And that becomes difficult because there's a lot of variability in terms of the care that is offered in different counties based on the emphasis or the priorities of the different governors or leadership in those counties. Again, at national level, we try to coordinate this. This has been typified, for example, when it comes to the national cancer centers. Cancer centers, we have several. They're not going to be we don't even have one in each county. And we've got equipment which is placed there, but the question is who runs it and who incurs the cost. For example, you have a county like Nakuru, where they will say, no, we are seeing patients all the way from Nyandarua and all these other surrounding counties. The budget for maintaining this equipment cannot be the role of Nakuru County alone. And then at national government level, we might not have the resources to be able to maintain the equipment. So there's a lot of issues that come up, but in general, political influence, the good thing with politicians is politicians tend to listen to what they call the ground. And cancer is a very emotive issue. So the tendency is you very rarely find politicians making any decisions that go at cross purposes with what cancer patients require, because at the end of the day, those are the voters. So I don't know if I've answered your question, but if you want to ask something more specific about the political influence, then I'll be willing to answer it.
Okay. I can't see any other questions, and at least the talk is a great insight and an opportunity for us to make reflections. I think unless another question pops up, allow me to make a quick announcement before we conclude the webinar. We planning for our next 7th National Palliative Care Conference, which brings together different stakeholders, palliative care providers, governments, both national and county, partners, supporters, individuals, patients, families, to a forum where we share matters, anything matters palliative care. And this time we're going down coast in Mombasa. This is happening off season in February next year, 24th to the 27th of February, and we start to make invitations, so book your calendars in. We'll be giving more information through our social media pages and in different other fora. So start to diarize and start to prepare. We would love to see you there. as we talk best practices matters palliative care. And leadership would be part of the things that we would want to hear or to see. And so as we conclude, Doc, maybe you could just mention something around my earlier question. It was a talk which was in a forum that I was in 2-3 days ago. People saying some of the problems that some of the facilities may have is around, the founder syndrome, people not being really comfortable or ready to release what they began, and yet, transition is inevitable sometimes. I don't know, what is your comment on that? And then you could give us your closing remarks. I see a comment from Raphael. Thank you, Dr. Olueni, for the great presentation. I've witnessed some strain between NCIK and NCCP, and he wants a polite comment. Yeah.
Let me, in fact, address this issue of NCI and NCCP, first of all, directly. Yes, that observation is correct. And it is something which is historical, and it's something which when I joined the organization, I noticed, and it's something that needs to be addressed. Now, the conflict, I would not want to call it conflict. I think it's a jurisdictional conflict, because NCI Kenya was created by an act in 2012. And you remember, historically, this was a time when, coincidentally, we had got the Ministry of Health was split up into Ministry of Medical Services and Ministry of Public Health. Coincidentally, both the people who were heading those ministries at that time, cabinet secretaries or ministers, we called them then, were people who were very passionate about cancer for personal reasons. So they pushed the National Cancer Prevention and Control Act, and that was in 2012, and it passed. Now, subsequently, things kind of slowed down, so the regulations were never implemented and so on. Now, if you ask me, the act in itself, the problem we have is one with the law in how it was crafted. There was some overlap in terms of the functions. Now, each organization, so in this particular case, both of these organizations are right. There's some overlap. And therefore, there seems to be some jurisdictional conflict in terms of who performs what role. My personal opinion is, first of all, that both organizations are right. I think anything to do with the Ministry of Health should be more involved in terms of policy, and implementation should be left to NCI Kenya. That is not necessarily to say that NCI Kenya cannot perform an advisory type role, and it's actually stated in the Act. So there are certain things that we are ironing through, and that this conflict is important to address, because if we are both organizations working within the same space, we should not be seen to be working at cross purposes or having conflicts, because again, it jeopardizes our work. And also in terms of partnership with other organizations, it kind of sends the wrong signal. So it's something that is actively being addressed, and in terms of tidying up this. But personally, I keep saying it's even a relationship, even in a marriage. It all depends on how the association is. It sets the background tone. If you've got a friend of yours who comes and hammers you on the back, it might be a friendly pact. If an enemy does the same thing, then it becomes war, isn't it? So it's all about perception. That's why I'm saying at the end of the day, we have to focus. The issue is we are all working in the same space, and we have got similar goals and objectives. So the more players we have, our roles, even where there's overlap, should be complementary and not be seen to be conflicting. Sometimes it's because of the personalities and some of the history that goes into it. But for me, at this point, I think our roles should be complementary, and there's so much work to be done in this space that I don't think there's room for us to be fighting about who does what, as long as it gets done. Sorry, David, I seem to have forgotten your other questions now.
Well said, yeah, and you've answered really well. And one thing that we do from Kehpca perspective, we work with all these stakeholders. We work with NCAK, we have good working relationships with the Cancer Institute, and as well, we equally work very nicely with NCCP. And I like your emphasis that we should complement each other. At the end of the day, it's providing direction, providing some support to the patients that we serve. And the conditions that they have do not know titles. They just need service. And so that is what should be our driving force. And so, yeah, I'd requested that you make a comment around, the founder aspects, and then transition, and then you could conclude with any comments that you have. And I see there is a comment from Victor that is looking forward to many more of this kind of nice presentations and great eloquence, he says. Thank you. Over to you, Dr.
You know what happens a lot of the time with organizations that we found is, again, the difficulty of letting go. And I liken it also to just, for example, running a family business. Sometimes when you run a family business, you start as what they call a mom and pop shop. So you start small and you start growing. The question a lot of the time is, when do you let go of the reins of power and let the organization grow? Because sometimes what happens is the moment, and I liken it to the difference between being what they refer to as an entrepreneur and a small business person. A small business person wants to control everything, make all the decisions. An entrepreneur leverages other people's resources. So what happens is, you don't necessarily have to own everything. You look and say, if what you need is to have an item delivered from point A to point B, you've got the choice about saying, I will wait until the day I own a truck myself to deliver items from point A to point B, or I could use somebody else's truck to deliver the goods from point A to point B. The end result is the same, but if you're waiting to own the truck yourself, chances are you will take much longer to get it done. So what I'm saying is leveraging resources, and that's what happens again within organizations. For example, I'm a medical doctor. I do not have the professional expertise to be able to manage accounting and so on. I can sit and try and do all those Excel spreadsheets and do financial statements all the time. Will I do them efficiently? No. So the truth of the matter is, we have to at some point be able to let go and let the organization grow. It's a question, if even when it comes to business, it's a question of whether you want to own 10%, 100% of a business that's worth 10 million, or you want to own 1% of a business that's worth $1 billion. That's the decision we have to make. So unfortunately, at some point, we have got to let go and be able to let the organization grow. So even when it comes to palliative care, you talk about hospices, most of them you'll find are centered around a particular individual who is the one who is the vision carrier and so on. But there has to be room. And that's why I talked about having an effective board and proper governance structures. Once you have those in place, then you're sure that that initial vision will be maintained regardless of who comes in. And then that way you can allow the organization to be able to achieve better on its mandate. Now, in terms of, if I was to say anything in closing, I must remind people that leadership is a privilege. Those of us who are in leadership positions are privileged, and we must make sure that we deliver on what people expect from us. That's why we say there's any transformational leaders, it's a paradoxical mix between professional competence and humility or modesty. There's someone who wrote a paper once and talked about what happens to people when they get into power. And most of us will have realized, you get people who get into power, and after 1 week, you cannot identify the person that they were before. Power, you've had the phrase power corrupts, and absolute power corrupts absolutely. There's someone who actually did a study, and this is a psychologist, and they said that they actually found that the kind of brain damage that power causes to people is similar to what people with traumatic brain injury experience. It is that bad. And that's why sometimes you've got somebody who goes into power, and I'm telling you, you cannot be able to identify who they are, because all of a sudden you call them by the regular name that you used to call them before, and they tell you now, I'm Mweshimiwa. You can't just refer to me like that, right? So what happens is, and this is one of the things that helped me even as I moved into this position of national leadership, you must always stay grounded and must stay focused on the reason why you were given that position. And that is what will help you keep you grounded. You must always have a support system of people who will keep you honest. Because in the absence of that, you've got a group of people who will surround you, who are going to become people who are praising you, and half the time they're telling you lies for their personal interests. And guess what? The day you leave that office, those people fizzle and disappear. Your phone doesn't ring anymore. And that's why I keep saying, for me, one of the things that has helped me most is the leadership position does not really define who I am. Right? It doesn't define who you are, and it can't. Because if that is what defines who you are, then you're going to change the moment you get in that leadership position. And the reverse is also true. When you lose that leadership position, you lose your identity. It has to be that you're confident enough to know who you are and what your value is. So the question is what role you can perform and what you can do for the people. But it's always important to stay humble and have humility. That's the advice I can give people, and make sure that remember, leadership is a privilege, and make sure that even when you leave that position, you'll be able to look back and say, this is what I achieved during that time. Otherwise, there's no point being there.
Wow. What a closing remark. That's quite heavy, and I think it's a good way of ending the webinar. Thank you for the emotions. Thank you for the hands. Thank you for the love. We truly appreciate. That said, our heartfelt thanks, Dr. Olweni, for agreeing to be our presenter tonight and sharing your knowledge and your experience. We truly appreciate that. Again, we acknowledge the partnership that we have with National Cancer Institute Kenya. I must acknowledge that to make this successful, I have a great team of my secretariat working behind the scenes to ensure that we learn and we keep very focused. Thank you, my team. May God bless all of us who decided to prioritize this and come to learn. Your great pillars in this field, and so feel appreciated and acknowledged. That said, then that brings us to the end of the webinar. We'll be having another one in the next week in Joinder with Faraja on non-medical support to patients or something. We will be able to share the posters in our social media platforms. And then in the next month, we'll also have another webinar. We will also share that information. So that's it. All the best, and I wish you a good night or a good morning, depending on where you are. Adios. Goodbye. God bless you.
Thank you, everyone. Good night.
Good night.